Tests for the elbow. Resistance isometric test. This is for the poser assessment of the elbow. For the assessment of flexion power mediated by the biceps brachii, the physician stabilizes the elbow at one hand and asks the patient to counteract the physician's attempt at pulling their arm down. For the extension power, which is mediated mostly by the triceps brachii muscle, the physician asks the patient to counteract their attempt to push the arm in. For supination and pronation, physician asks the patient to flex their elbow at 90 degrees. For assessment of supination, the doctor asks the patient to counteract their attempt at turning the palm down. For pronation, it's the palm up. Elbow stability test. To test the medial collateral ligament and lateral collateral ligament, the physician asks the patient to flex the elbow for about 20 to 30 degrees, which will unlock the olecranon from its fossil. For the medial collateral ligament, the physician applies a vagus, meaning lateral force in one hand while stabilizing the patient's elbow in the other. For lateral collateral ligament, while stabilizing the elbow, the doctor applies now a varus, meaning towards the middle force. To test anteroposterior stability, the examiner grasps the forearm while the patient's elbow is flexed at 90 degrees, then pushes and pulls on the humerus bone. Normally, no movement should occur. If movement is present, it suggests a destruction of the bone. Tennis elbow tests. Cousins test. Cousins test is also known as the resisted wrist extension test. It stimulates the extension of the extensor carpi radialis, longus, and brevis. The patient may be seated comfortably for this test. The patient's elbow is flexed at a 90-degree angle. The forearm is in a pronated position and their hand is in a slight radial deviation. The physician palpates the lateral epicondyle with their thumb, and their other hand is used to resist the patient's wrist extension. The test is positive if the patient experiences sharp, sudden, severe pain over the lateral epicondyle. Chair test. The patient is standing in front of a light chair. Their forearm is pronated, elbows fully extended, and shoulders adducted. They lift the chair while having their elbows fully extended till they reach an angle of 60 degrees. The test is positive when they feel a pain in their lateral epicondyle. Mills test. This test stimulates the extension of the extensor carpi radialis, longus, and brevis. The patient should be standing up. The physician palpates with one hand the region of insertion of the muscles on the humeral lateral epicondyle area. The patient's forearm is passively pronated, their wrist fully flexed, and a passive extension of the elbow is done. The test is positive if a pain is felt at the lateral epicondyle region. Moseley's test. This test stimulates the extensor digitorum muscle, which takes origin in the humeral lateral epicondyle. The patient is seated comfortably with their humerus stabilized and their forearm fully pronated. The physician palpates the patient's lateral epicondyle with one hand while resisting the extension of the third digit of the patient distally to their proximal interphalangeal joint. A positive test is indicated by pain over the lateral epicondyle. The coffee cup test by Coonrad and Hooper. While doing a specific activity such as picking up a full cup of coffee or a milk bottle, the patient is asked to rate their pain on a scale of 0 to 10. Polk's test. An object of 2.5 kilograms, a book for example, is lifted by the patient while having their elbow flexed and their forearm fully pronated. A positive test is indicated by pain over the lateral epicondyle, referring to tennis elbow. The physician asks the patient to repeat the same task, but this time with their forearm fully supine. A positive test is denoted when a pain is felt in the medial epicondyle, referring to golfer's elbow. Golfer's elbow tests. Golfer's elbow test. The patient is standing up and the physician fixes their humerus while palpating the medial epicondyle region. Then, the physician asks the patient to flex his elbow at a 90-degree angle and to supinate their hand. The physician extends the patient's hand and then extends their elbow fully. The test is positive if the patient feels sharp pain in their medial epicondyle. Violinist's maneuver. The physician asks the patient to flex his wrist as if he's playing the violin against a certain resistance. A sharp pain on the medial epicondylar region indicates golfer's elbow syndrome. Other tests. Elbow flexion test. The patient has their arms in the anatomical position, their elbows fully flexed, and their wrists fully extended to avoid compression of the median nerve at the wrist, which can bring confusion to the test. This position should be maintained for up to 3 minutes. Any tingling or numbness felt along the dermatome of the ulnar nerve indicates a positive result of this test, which means that the patient suffers from the cubital tunnel syndrome. Cubital tunnel syndrome test. Cubital tunnel syndrome is caused by the irritation of the ulnar nerve in the cubital tunnel. Symptoms are mainly paresthesia radiating down the forearm to the ring and little fingers. We perform Tinel's sign and the elbow flexion test. Elbows compartments. Examination of sensations. To examine the median nerve, the physician palps the index finger. To examine the radial nerve, the physician palps the dorsal web space of the thumb and index finger. To examine the ulnar nerve, the physician palps the fifth finger.